I started to not give you the invite, Johnny. And then just be like, yeah, guys, I didn't give Johnny the invite. I gave him a bad one. We'll just
Is this what it's gonna be? All right, let's save that now. All
No,
right, welcome back to Owens Coverage Science Podcast. I'm back, baby. Johnny Owens is back.
here's
I
Johnny.
got so many tweets of like, what the hell the last podcast was that? Text messages like, dude, this was garbage. Can you please come back on? So I'm back. Actually, I got the opposite, man. I had some people like, dude, they don't even need you. Why are you even on there? I heard Ben talk more in that podcast than he's done in every podcast we've had.
Yeah, I went out and I ran the
Opportunity.
time.
Somebody had to fill in the comedic relief, that was that spot wasn't occupied.
Geez.
Well, yeah, dude. Well, I almost died. I had Montezuma's revenge. I lost 12 pounds. And the day of our podcast, I had to go to the hospital and get fluids. 2 bags of magnesium, which took 5 hours because they have to drip it so slow. So, anyways, sorry I missed you, fellas. You'll be happy to know I put the weight back on.
Nice.
All right, today we've got controversy, baby. We've got a couple papers that have come out on ACL and BFR that I think there's been some Twitter kind of action on it. And there's also been some texts that I've received, like, have you seen this type of thing? One of them, it's kind of almost like a clickbait type of title, which catches your attention, and that's the trend nowadays, is to do the sexy title on the paper. But we're going to jump right into it. So the first one, I'm going to let Z break it down. He's already brought out his little stats machine and his calculator and has been looking at all the numbers and everything on this. So Zach, without further ado, man, describe this paper, give us the title, and let's get into this bad boy.
So kind of starts out in quotations, real world, and then clinical implementation of blood flow restriction therapy does not increase quadriceps strength after a quad tendon autograft ACL reconstruction. From there, basically the question that these researchers wanted to ask was, does BFR result in increased quadriceps strength at different postoperative strength assessments? And does BFR result in significant increases in quadriceps strength over time compared to traditional rehabilitation protocols? The purpose to evaluate the effect of a postoperative rehabilitation plan with the real-world clinical application of blood flow restriction therapy compared with standard rehabilitation without BFR following a quad tendon autograft ACL reconstruction. Specifically examining quadriceps strength parameters over time. They hypothesized the addition of blood flow restriction therapy would result in increased quadriceps strength at postoperative strength measurement time points and a significant increase in quadriceps strength over time between repeated strength measurement time points compared with standard rehabilitative protocols without blood flow restriction.
Woof, that was a lot.
Yeah, I mean,
when I heard real world at first in quotations, I thought it was a BFR study on the cast from Real World from MTV.
It's like, I was like,
Would have
an
been
MTV
badass.
thing.
Yeah. In quotations.
Who are the people on Real World? There was
there were so many. Puck. It's been a long time.
There was like 20-something seasons, Kyle.
Dude. Come on, Kyle.
Oh, they were? Oh, I don't know.
So that's
Kyle's more of a VH1 guy.
He's Real Housewives on Bravo guy.
Oh, definitely not.
But so then kind of getting into the nuts and bolts of this deal was it was retrospective in design. And so what they did was they looked at their inclusion criteria were individuals greater than the age of 14 who underwent an ACL reconstruction between 2016 and 2021. They had to receive at least 2 quantitative isometric strength measurements. And so from there that included 45 individuals in the BFR group And then they had 36 in the traditional rehab group. Now, they tested 3 time points, and you'll see that there's a big drop off in the traditional rehab group between 2 and 3 assessments. So again, the BFR group started with 45 individuals getting at least 2. 32 of those individuals then had a total of 3 strength assessments. The traditional rehab group started with 36 that received the 2 strength assessments, and then it cut in half, and only 18 went on and had a 3rd measurement performed. So exclusion criteria was an ACL reconstruction with a graft choice other than a quad tendon. If they had either incomplete or inadequate postoperative strength measurements, different types of ACLs, double bundle, hamstring, patellar tendon, allograft, and such. If they also had a previous ACL injury on that side or a contralateral ACL reconstruction, osteochondral defects, meniscus repairs, partial meniscectomies, and then also if they had a Lemire procedure or a lateral extra-articular tenodesis. So if they had those done, they were not included in the analysis. Now, when you look at individuals who were enrolled specifically in the BFR group, it was interesting, the wording and how they phrased everything. So BFR therapy was used by some of the physical therapists as a standard modality with all of their patients, kind of in this post-operative ACL rehab, while other physical therapists reserve the use of BFR for patients who they thought may struggle with strength recovery. The BFR was started somewhere between 2 to 6 weeks post-operatively. So it kind of sets the stage, right? I mean, you're looking at this, and and just so everyone's familiar too, this was a multi-center trial within the same hospital system, but they have a ton of different clinics. And so from there, numerous therapists, different clinics, different locations, some of which use it as a standard of care. Like, this is what I'm doing when I get a post-op ACL, we're doing BFR. Others were like, well, you know what we're going to do is we're going to hold off. And I don't really think I have a need for BFR in an acute post-op situation. And they'll then try somewhere in that like 2 to 4 or 2 to 6 week time period, be like, hey, this individual is struggling. They're not making the progress that I think they should. Then we'll start doing BFR. So you might say that some hard gainers were then moved into the BFR group and contributed that to the analysis. And so from there, it gets interesting too, looking at
Wait, Zach,
yeah.
Hey, back. What do you mean by hard gainers?
So like a hard gainer is going to be someone who is going to have difficulty putting muscle back on, whether that's muscle mass or muscle strength. Like, they're just going to struggle.
Okay. So you're
For
essentially
instance,
saying
you Kyle versus me.
Yeah, exactly.
So you would be a hard gainer.
Yeah.
I'm a gainer.
See, well, that's important, because I literally thought you meant the opposite. Like, these people are really gaining muscle faster, they're gaining it hard, they're moving. So what you're saying is there's a real strong likelihood, which they did mention in their limitations.
They mentioned this. Yeah.
There's a strong likelihood that they had a selection bias, and that the people that were getting added to the BFR group were people that were essentially kind of behind where they would expect them to be. They were not moving along.
It gets tricky teasing that out, because I think, without getting too far ahead, one of the limitations is
data.
We don't have basically who the numbers that were enrolled in BFR immediately, and then those who were in the delayed group, or like who moved over afterwards when the therapist thought,
when they were
like,
struggling,
this person's not really making progress. So you don't really know. But when you look at the demographics, right? So when you look at the mean age, pretty close, like 22 and 22 years old in the BFR group. Traditional rehab was 19. But when you look at the age range, dude,
Yeah.
it runs the gamut, right? I mean, you'd
Yeah.
have 17 to 45-year-olds in the BFR group, and in your traditional rehab group, you're looking at 14 to 23. So, you know, much younger group. And then you take a look at gender. Um, 26 females were in the BFR group. Now that basically is 57% of that of the group were females. But then you take a look at traditional rehab, and only 13 were females, and so now and that's 37%. They reported it there was no significant difference there. I think like maybe it was very, very close on the chi-squared that they ran. They didn't put the p-value in there, but I would suspect that difference is somewhat close to reaching significance.
Yeah, I hate not seeing a p-value and just put in not significant. I mean,
right. You would, I
that.
think if you can easily run a chi-square in Excel,
if you ran it, yeah,
and you will see that number is close to reaching significance.
Yeah.
So, and then I think then you look at time points of assessment for the strength. Test point 1 in the BFR group was at 4.8 months versus traditional rehab was at 5.6. Time point 2 was 7.5 months. Traditional rehab was 8.6 months. And then the final time point from surgery to strength assessment in the BFR group was 11.1, and traditional rehab was 11.8 months. This gets interesting as well because you're looking at a 4-week difference. Basically, there's a 1-month difference between assessments, except for the final assessment.
Yeah, and the BFR is behind in that 1 month. So
exactly.
Think about your patient at 18 weeks versus 22 weeks. They're going to be different.
That's it. And I think like at least for me, one of the interval at which I assess strength is every 4 weeks. I mean, it's enough time where you're going to get a strength difference. You should have a change in strength in 4 weeks.
When people ask us, how long should I do my BFR? When we send up a trial, it's like, well, we need at least 4 to 6 weeks. That's kind of the minimum. But you would hope at 4 weeks you're seeing some change. So
yeah,
that's kind of a big problem. Even though again, not significant. Anyone in the rehab world knows a month difference in post-op ACLs is a pretty big deal.
Yeah, I'm sure like when you run, the Mann-Whitney test, which is what they use for that, you're looking at like literally one number difference. Of course, like one number is not going to make a statistical like literally going from like 4 to 5 is not going to be statistically significant, but man, on the clinical side of things, that's a pretty significant gap in time.
Well, this is where the term real world kicks in.
it does seem very real world. And Zach, I may be jumping ahead of you here, but something that for me makes it again very hard to look at these two groups and compare them is the BFR group. They reported some numbers on the number of sessions before the first measurement, in between the first and second, in between the second and third. And we don't have any of that information on the standard of care group on, did they train at the same frequency? Was it more frequent? What does that
even close?
What does that look like? Yeah. I mean, and just the huge variance in sessions, for time point 1, you've got 18 sessions on average for the BFR group, but that's plus or minus 15.5. And then for the second measurement between 1 and 2, you've got 8 sessions plus or minus 6.5. So you might have 1.5 sessions, whatever that is, or, you might have 14 sessions. And that makes, to me, a huge difference in what that change is going to be between measurement to 1 and 2. So
yeah, the wide kind of distribution is another, challenge. But then, from there, so obviously our independent variables is going to be the type of rehab, BFR or traditional rehab. Dependent variable or variables was isometric strength and a biodex, and then limb symmetry index as well. And so, just challenges with limb symmetry index. Ideally you want to know what the strength was going into the surgery.
So explain LSI for some people that might not know it.
Yeah. So what a limb symmetry index is you're literally just looking at the difference between your involved and non-involved side. Basically, there's two different formulas that you can derive that. Very simple, just divide them out, and you can get a limb symmetry index that way. And kind of
take a peak torque before surgery on the uninvolved side.
Yeah.
Right. And then you're going to compare your peak torque on your involved side post-operatively to the pre-op uninvolved peak torque.
And so when you get your peak torque measurement, you divide the bad leg by the good leg, and it's going to give you a percentage. It's going to tell you how close the bad leg is to the good leg, or the involved side to the uninvolved side. And then people historically would track that. And one of the common cutoffs is you want a limb symmetry index at the end of rehab at 90%. So you want no more than a 10% difference in strength between your involved and uninvolved side. I think there's limitations to the limb symmetry index, and that's why people have moved away from that. And they look now at peak torque to body weight ratios as kind of where we want to be. Now, a limb symmetry index is good, but you need a normative value to compare that to, because you don't know. I mean, you could have a limb symmetry index of 0.95, but your peak torques are the person's just very weak altogether. But
their other leg's weak.
Yeah. And right. So, I mean, like the goal is they need to get stronger just altogether. Without
the data of the uninvolved limb, LSI is really hard to interpret, because LSI could be improving, but their other legs getting weaker. And that's what happened in their last two time points. The non-BFR group got weaker and their LSI didn't change really. So that means the other leg got weaker as well.
Yeah. That's exactly it. Or, the side note is there's a bit of a debate, I think, with people as to how hard you should train the good leg, because you don't want the good leg to get really strong. I'm of the camp of I want the good leg to be as strong as possible. So we always have.
How is that even a debate?
I know, honestly.
Is there a strong?
I would leave that. I'd be like, no, we're training everything as hard as we can.
Because you need the good leg to be the reference standard. Yeah. But then what happens is those people who don't really train the good leg because they don't want it to get too far ahead, when they do start training the good leg, it takes off, and now your limb symmetry index appeared to be close at one point.
I don't think we got to worry too hard about those people, because I guarantee you they're using like Bosu balls and shit when they're rehabbing too. So, right? Honestly.
Anyways,
adding back to the deal.
They got some of those little egg weight shaker maraca things that
shake weights.
Shake weights, yeah.
No, but that's not what the guy calls them. The wet guy. Anyway,
I know.
You're talking about Dave.
Yeah, the wet guy.
The wet method.
Bosu guy.
Yeah, the pulsers.
There you go.
Pulsers. Okay.
Yeah. All right. So now from there, moving into the results. So the first assessment, BFR MVIC was at 95.6 foot-pounds. Their traditional rehab group was at 111.2 foot-pounds. That there was a significant difference there between groups at the first time point. we had a limb symmetry index of 68% in the BFR group and a limb symmetry index of 78% in the traditional rehab group. That did not reach significance. So there was no significant difference in limb symmetry index between groups at the first assessment. Now you move into the second assessment. And this was roughly around like 8-9 visits later. And so
I would say, if I could interrupt, Zach, just back to the point we made earlier, the difference between time points here,
it's a month later.
Is a month.
Yeah.
And it shows like, hey, there's a significant difference here between these people's peak torque at this time point, just to kind of support
a month later. And we already know they probably took weaker people, which they said they did in the BFR group. And so this first time point, it's kind of all over the place.
Yeah. And now, so we moved to time point 2. BFR group has a peak torque of 118.2 foot-pounds. That was a change compared to the first assessment point of 22.2%. Traditional rehab group had a peak torque of 134.3 with a 24% change. So
I had to look at that again, Zach. That's not the percent change. That's the difference. Yeah.
You're right.
That threw me off because I did percent change and I was like, this does not make sense. These numbers don't line up.
You're right. I stand correct. That is the absolute change in peak torque. So basically it went from 95.6 to 118.2. It was a 22.2 foot-pound change. And then the MVIC group went from 111.2 to 134.3 for a 24.1 foot-pound change.
That was out to 24% change and 21% change, just FYI, in that first go round.
And that did not reach significance. Now, looking at limb symmetry indexes at assessment 2, it was 81%.
Hang on one second. When we say, because this is confusing me when I'm looking at this. When we say that's not significant, what we're saying is there's no significant difference between your BFR group and your non-BFR group. What we're not saying is it was not a significant difference between Biodex 1 and Biodex 2. They did not report that information. They didn't tell us if that change is significant. We would assume it is a 20-something% change, and generally speaking, a 10% change when he's talking to force output is significant, but they did not report whether or not the change from test 1 to test 2 within the group was a significant change.
You're right.
It was between groups. That's it.
And you would have thought that you would run that.
Yeah. Because the first to third, we'll get into that. It was a big difference in the BFR.
Right.
Right. It's almost 50%.
And then you look at a limb symmetry index at assessment 2. The BFR group is now at 81%. The traditional rehab group was at 90%, with a change of it was a 12% change out of the
12%, 12 foot-pounds.
No, we're on limb symmetry index now. On assessment,
it's the same thing. They just added the numbers. It was actually a 19% change and a 15% change. So they did the same thing in the LSI.
Yeah.
I thought it was a percent change. Okay.
No, they just did 81 minus 68.
Also, right? There's problems. They didn't give us values here. So Zach keeps saying foot-pounds just because he knows that's what peak torque's reported in, but it's not actually shown.
Yeah, the peak torque was never they never said whether they use Newton meters or foot-pounds.
Yeah.
I'm assuming it's foot-pounds.
Right. Just based on your knowledge.
Yeah, so Zach, they just subtracted it's the absolute value. So between LSI of 1 and LSI of 2, they just subtracted those numbers. You got 12. The percent change in the BFR group was actually 19%. But
Okay.
this could get kind of complicated for people. We need graphs or something on this.
And then
Charts.
the change was 12 in the for the traditional rehab group. So yeah, they went from 78% limb symmetry index to 90%. And then the peak torque values, but that did reach significance between groups, which was interesting because the assessment one,
Yeah.
which was pretty much the same
10%.
difference,
10% versus 9%. Yeah.
didn't reach significance, but then at assessment
And reached
two,
it by a lot too, 0.02.
yeah,
You know, that's again puzzling how that first one.
right. You
Yeah.
didn't reach significance there, but you did in assessment two. And then when you look at the standard deviations, extremely wide at assessment two. And for the traditional rehab group, and it was much more narrow within that BFR group on the limb symmetry index. Moving to assessment three for peak torque, the BFR group had 138.5 foot-pounds compared to 130.7 for the traditional loading group. No significant difference between groups there. Limb symmetry index at assessment three was 87% for the BFR group, and then 91% for the traditional loading group. This is ultimately, I think, we talked about towards the very beginning and whatnot. One of the challenges with interpreting all this is when you look at their tables. So for their peak torque was in table two, assessment two, 134.3, and then assessment three was at 130.7. So they actually, according to this table, got weaker slightly for the traditional loading group. But then when you go down to table three, which is just below that, and you look at the change in peak torque between Biodex assessment 2 and 3, they report that there was an 8.9 foot-pound increase. I don't know where that number comes from.
Yeah, I was trying to see, does that work through the standard deviation? That really threw me off as well. Is that number just a typo?
Because all the other numbers pretty much like somewhat check out. Like if you just do the subtraction, the difference between assessments, they're pretty darn close to what's reported. But that's like that's going to be roughly a 12 foot-pound difference.
Yeah.
You know, when you basically, you're saying they gained about 9 foot-pounds when they actually lost over 3 foot-pounds.
Yeah, that makes no sense on that one. So I think I like to just think about percent change, even though that's kind of sometimes a no-no when you're doing the actual research, but it's easier to digest for me. The BFR group, the first test, they tested them a month earlier than they did the standard of care group, right? So we know that's probably a problem. The BFR group between test 1 and 2 got 24% stronger, and the standard care group got 21%. Between tests 2 and 3, the BFR group got 17% stronger, but the standard care group got 3% weaker. But the big dog I think you would look at is, okay, well, what was between test 1 and test 3? What was the percent change? The percent change for BFR was 45% increase, and it was 18% for the standard of care group. Standard care group started stronger and only improved 18% over that time, where the BFR group increased 45%. Now, again, it's kind of fudged numbers because these time points aren't the same.
Yeah. But
it still kind of helps when I look at that. And then if you look at the LSI, between 1 and 2, the BFR group got 19% stronger versus 15% of the non-BFR. Between 2 and 3, the BFR group got 7% stronger. The non-BFR had no change, basically. And between that first test and the third test, if you look at limb symmetry index, the BFR group improved 28% compared to 17%. And again, LSI is kind of we don't know, because we don't know if the other leg's getting stronger. I mean, we have BFR studies that show this crossover effect in the lower extremity. So it could be that that leg was getting stronger too. And that makes the BFR gains even more impressive because they're chasing a stronger leg. And obviously, the leg got weaker in the standard of care group. The uninvolved leg got weaker because the involved leg got weaker between test 2 and 3, and the limb symmetry index didn't change. So that means the other leg would have had to have got weaker. So they weren't doing this like comparing it to a pre-op uninvolved test. They must have been checking time points bilateral at each point, which is
I think
fine.
the other thing we do kind of have to remember, especially on the uninvolved, excuse me, not in the control group or the no BFR group, was they lost subjects too. And
So I think,
presumably you would think that
yeah,
they lost the subjects that were doing better,
yeah,
Tested out.
because they just didn't come back. So that might be creating a little bit of noise there for us too, which is
Well,
yeah.
confusing,
That's
and
exactly
making
what I
that
thought too,
group
Kyle.
not look good. Yeah.
I thought that the basically, again, like with the standard being like, if you're going to base rehab criteria off limb symmetry index, you get to 90%, and then you basically either, depending on who you are, what type of individual you are, go work with a strength coach, or you're good, go do whatever.
Yeah.
That's what I thought with basically they lost half their sample after the second kind of follow-up.
Well, and as we talked about at the beginning, we know the BFR group was at least somewhat heavy with people that were struggling with restoring their strength.
Yeah.
Struggling, older, more
Yeah.
females, significantly more, it sounds like, from Zach's test. Yeah.
And they
And
did
then
at least as
measured
well.
They
as
had their
the other
time
group.
points measured early. Yeah. Yeah. So I think our point was, because I can already see the next orthopedic conference I speak at, guys coming up to me like, "Hey, Johnny, did you see the real world paper?" It doesn't work in the real world type of thing. And they put that in their intro, like all these other trials were in controlled lab environments. And it's like, well, no, they're not. That's where the testing is done, but they're doing the studies in the clinic. It is a controlled, standardized plan of care and controlled time points, but it's not like it's all done in Jeremy Lineke's lab type of thing.
Yeah.
Well, and they lost me when they said it was real world BFR, but then they said they targeted 30, 15, 15, 15 with 80% occlusion at 30 to 40% of a 1 rep max as their BFR training. And that is something that does not happen in the real world unless we're not very good at assessing rep maxes. Because if anyone's ever actually done this at 30 to 40% rep max, 80% occlusion and 75 reps don't happen ever.
I think we should from now on say we tried to do 80% limb occlusion, but some of the patients couldn't handle it. I mean, in our giant femur trial that just finished, we had to document every time we changed the pressure. They have all that data to spin a second paper of like how many people actually were able to do it at these different pressures or at that pressure.
Did y'all pay attention at all to how they ran their power analysis? And did that red flag you at all? Like, I don't really understand this. It says an a priori power analysis was conducted utilizing data from a previous study comparing knee extension strength in patients undergoing BFR therapy versus those that did not receive BFR.
Yeah, they use Luke's.
The reference they gave. Oh
no, it's not.
Chang's,
it's a Nova,
and it's not even published. That paper's not even out. So I don't know. And if you notice, like the control group had to be 18 patients, which is exactly what it is, in that third time point. I mean, that's their that's their end. They hit that on the number. So you just kind of wonder, like, man, I mean, I think, well, Zach, you ran some of these numbers. It's like if there was literally like one more person in that control group or the BFR group doing good or bad, they reach significance.
Yeah, the big one was the demographics.
Yeah.
And that's the thing, you know, and I mean, this is one of the challenges. Like, what's a good peak torque? Like, what does a good peak torque? I mean, that's like a bench press. What's a good bench press number? What's a good squat 1 RM? I mean,
Right.
without having a literally being able to put this into perspective, peak torque doesn't tell us much. I mean, unless you look at an individual that you're testing, and then you can be like, oh, this is the improvement we got in your strength numbers. But again, like, you can just take a look at, like, you
Kind
take
of
a
like
180
taking the
pound
pressure out
guy.
of the air.
Yeah, you take a 180 pound guy and a 120 pound female, or a 120 pound guy. It doesn't even really matter. It's body weight, right? And so, you know, the goal with ACL rehab, or the goal with quad strength, I'll just say, is you want your strength to be equal to your body weight. You're not going to have a 120 pound individual generating 180 pounds of force out of their quad.
I was gonna say, let's be a little more specific what we say, because we shouldn't say strength. We should say your isometric force production out of your involved limb should be equal to your body weight. So if you're a 180
Yeah.
pound guy, you should be able to kick isometrically at 180 foot pounds of torque.
And that pretty much always, it's going to ballpark to 3 Newton meters per kilogram. There's
Right.
good data across the lifespan on that. And so that's the big challenge, you know, when you only have one group has 37% of their participants as one gender, and then the other one, you know, 57%. And so, and again, you know, you take that aspect of it, and then you say, we put the hard gainers, or the people that were struggling to increase strength, into one group. I mean, it's like,
I wish I
that's,
could design studies like that. That's why
that would
retrospective,
that
man.
would be like, you know, my real world example is like, you know, I'm going to put the weak people that aren't making progress on someone else's schedule, and I'm just going to let them deal with those results, and I'm just going to pad my own results. Yeah, I mean,
Yeah. Well, I think we broke down our thoughts on this. I think we hit the key takeaways. Don't you guys feel good about it? Anything we need to add? Kyle, I bet they got Eddie Chang.
What's that?
I bet they got Eddie Chang's. Eddie's presented that paper, and I think he won an award for it at AOSSM. So I bet they just got his data from his present when he was there.
Yeah. I was just like, because I looked it up. I was searching for it everywhere, trying to find, I'm like, where did they get this from?
Yeah, it's just the AOSSM.
I made up some alternate titles for this study, because y'all know how I get triggered about titles. So this will be my first one. Honestly, my first one is my favorite, because they legitimately could have said this: real world clinical implementation of BFR therapy increases quad strength after quad tendon autograft ACL reconstruction. They legitimately could have said the exact opposite, and that would have been truthful as well. I also wrote this because they I don't know if y'all caught this, but in their introduction, they were talking about review papers, and they said, hang on, let me put it up. Let me read it. I'll read it verbatim because I don't want to screw it up. While rehab protocol, no, that's not it. Currently, limited studies of small sample size, heterogeneous strength outcome measurements have been unable to draw firm conclusions on postoperative strength outcomes undergoing BFR therapy. We would all agree with that, I think. But then they also said within that same, as part of the post-op rehab protocol following quad tendon autograft ACLr, there aren't any studies published with quad tendon ACLr.
No.
Eddie Cheng's group had 6 subjects because I went to Clin Trials. They had like 6 subjects that were quad tendon.
Our DOD trial is only quad tendons.
Only quad tendon.
I
was
we
setting you up,
going
Johnny. I was
right
bringing
now.
that. I was like,
Thank
hey,
you.
Johnny, you know anybody doing a quad tendon trial? So I
they
said,
stole our thunder because
they stole
our
it.
thing was like,
but
no
they
one's looked
didn't.
at quad tendon.
They didn't because you can use
It's
this title.
retrospective.
This is the title you can use now, Johnny. The first report of BFR therapy used in the rehab of ACLr via quad tendon autograft. And then I put a retrospective review, but that was me recycling that. But you can steal that because they didn't. I thought this could have been an appropriate title. Timing of force testing may influence findings in the early stages of rehab following ACLr via quad tendon autograft.
That's good.
Therapists favor utilizing BFR over standard rehab when managing ACLr via quad tendon. I mean, that would have been fair because they had more subjects substantially in their BFR group. Heterogeneous protocols and samples once again demonstrate the difficulty of rehab trials. Could have been another possible title. And then lastly, absolute force measurements and LSIs are not sensitive enough to differentiate the effectiveness of 2 different rehab protocols following ACLr.
I like it.
All great titles.
Yeah.
That would have applied perfectly, and we didn't have to, use, I don't know, maybe whatever clickbait title the journal wanted to use. I don't know how that works.
If you want to write a letter to the editor and suggest new titles, I'll let you do it. Although I think you might have a problem with who the editor is.
I don't have a problem.
He's a great person. These are great people.
Yeah. Well, I mean, Kyle, we need to get you some more, muscle mag or meathead terminology to work in there, based on the fact that you're asking about hard gainers. I
don't know.
That's standard terminology. That's gym bro talk.
I don't know that.
I think Joe Weider invented it.
Sorry.
All right, Ben. Roll into this our second paper, man.
Yeah, this so we've got this review paper, systematic review by Colombo et al. Title for this one is the comparison of blood flow restriction interventions to standard rehab after ACL injury, and I'm assuming they titled it after ACL injury as opposed to reconstruction based on the studies that were included. This is coming from a group over in the UK, and they were mainly looking at structuring this to examine the effectiveness of BFR versus similar rehab without BFR in patients undergoing ACL reconstruction. So they were primarily looking to assess knee extensor and flexor strength. It also had to have some imaging that was either MRI or ultrasound included. And then they also looked at a tertiary knee-specific patient-reported outcome measures. So this is going to come as a shock to everyone here that there were not that many studies that ended up meeting their inclusion criteria for all these things. Overall,
one thing.
Yeah, the imaging requirements may have excluded a few. And so there's 5 studies that met the inclusion criteria, which of course makes it hard to create any real statistical power and generalize the results. Overall, you've got 130 total participants that were included in this systematic review. 78 of those fit into the BFR. 52 of those would be either sham or control numbers. And we've got 2 prehab studies, which is, again, why I'm assuming we've got ACL injury in the title as opposed to just ACL reconstruction. Those were from Zargi and Kaysen's lab. And then you've got 3 rehab studies that ended up meeting the inclusion criteria. So overall, the big findings that they came up with were that the results are unclear as to whether or not BFR can consistently create increases in knee extensor and flexor strength after ACL reconstruction. They did say BFR may improve the, knee specific functional outcomes and patient reported outcome scores, but again, not enough there to say that that's consistent. And it's, I think, really what we kind of all expected going into this, as far as, we look at the studies that met inclusion criteria, and overall, there's not going to be enough there to say we have this clear-cut answer that BFR is the, best thing post ACL reconstruction compared to the, control or standard of care in these studies that they used. I mean, even in, I think my bias is the Hughes study for leg press after ACL reconstruction is probably the best one of the bunch. And they compared BFR with low load to lifting heavy after an ACL reconstruction and showed that BFR was just as good as lifting heavy for making you better at leg press and for making your thigh bigger. And so that's, again, not a huge shock that BFR didn't outperform lifting heavy. They did have some improvements in pain. They had some improvements in functional outcome, had some improvements in swelling and faster return range of motion, and some little things that seem to kind of say
but those
BFR
aren't little.
better.
I was going to say, those aren't little.
Yeah.
Yeah.
Well, I mean, just as far as like what would create statistical changes in a review.
But I think they made it out that like Luke's paper was the winner, pretty much. It sounded like when they're like looking at this. But yeah, BFR, the low load versus lifting heavy, there was no difference between the groups. Great, BFR is pretty equal to lifting heavy, but to have less pain, less swelling, better range of motion, improved functional, improved self-reported in the BFR group, that's kind of the heavy hitters from a clinical side. So I like that.
And I think that, I mean, we're only talking one exercise there, right? So like that, like one exercise made a difference. So I think, there's a couple different ways to look at that, man. All right, what could we get if we included a number of other BFR exercises in just one? But also, like, just one heavy loaded exercise created that big of a difference,
right?
And the irritability of a knee, and that's pretty significant,
right?
Statistically, and just from the perspective of rehab,
right? Well, and looking at the other studies included here, you've got the two rehab ACL studies from Zargi and Kaysen, so same lab, and one is 5 exercise sessions in the 8 days leading up to an ACL reconstruction, and you only have one exercise being performed there too. You've got a knee extension to failure with BFR or no BFR, and they only focus in this review at the 12-week time point, which is their last time point. They're looking at, muscular endurance with a sustained isometric and blood flow of the quad, and there was no statistical difference between groups there. But the 1 month time point, there's a very significant difference between groups. Right. And so, again, it's maybe there's some picking and choosing of what, is meaningful there, but also it's one exercise for 5 sessions.
Right.
And, seems
but then when you read that paper, you get the kind of spirit. Yeah. But also the spirit of what they were looking at. They were like, could BFR increase your blood flow, your capillarization, and maintain it post-surgery? Because post-surgery, when you have a reperfusion of the tourniquet, you have damage to the vascular beds. And that's, some people think that's what really wipes out quad endurance. And so only 5 sessions, they increased the capillarization by 50% at week 4 versus the sham group, it was down 32%. And then the quad endurance, I forgot what the numbers were. It was
like a 30%.
30% difference, yeah.
Drop
in the control group.
The control and the BFR group didn't lose it at all.
Right.
Yeah. I mean, it's almost like, dude, if you could get in for 5 sessions, that first month might be money for your patients, because quad endurance is like one of the big issues of where you have instability and all the things you're nervous about in that first month. That quad being fatigued and something happens on a stair or something. So,
right.
The spirit of the study, and again, prehab versus post-op is probably going to be so different. I mean, if you look at the systematic review, two prehab studies. One did 5 sessions. One did 3 weeks or 9 sessions. And then you got one post reconstruction, which isn't even a BFR study. It's an IPC study, for what, 8 sessions or something like that for 2 weeks.
It's like 2 weeks.
And then you've got the ODA, which so many, it's a home-based protocol with here's your cuff, even though they didn't tell us what it was. Thanks for the thumbs up, Ben. And
I'm not doing anything.
but then you got Luke's, which is probably the best one out of all of them. So I mean, it's just so much heterogeneity between these studies. I don't know how we could get anything from a review on it.
Yep.
Yes.
So
Agreed.
and I think losing my train of thought on what the hell was I about to say, man? Someone take over. I'll remember it.
We'll edit all this out. Not really.
I don't want to steal your thunder, Ben.
We're live on YouTube right now.
No, you're good, man. I mean, I think for me, it was just looking at this review. There's just not great studies to pull information from. The fact that the Iverson and OTA studies met inclusion criteria, and some of the papers that I think we would all consider better rehab papers didn't meet the inclusion criteria because they didn't do MRI or ultrasound as part of the study. OTA, you've got a pressure reported, but no cuff width reported, and a home study where the exercises are not really loaded very well and not progressed well. And, shockingly, there's no huge differences to be found that are making this review look more meaningful. And then the Iverson paper, you take a cuff that we're all familiar with and you jerry rig it to put a hand pump on it instead of letting a computer, pressurize it like it's intended to be. And like you said, you just have basically IPC. You have intermittent inflations at a pressure that actually is something we don't actually know the pressure because it's not,
they Jimmy rigged a cuff. Yeah.
It's not being regulated the way it's intended to be. And, again, shockingly, that's not going to create the results that you would hope to create. Plus, it's the first 2 weeks, and it wasn't really, something where they did meaningful exercise along with it. So it's, it's good to break these things down because I think it's good to draw attention to the fact that, we're making statements based off of poor information, which is not, unexplored territory within the research world. But, somebody could look at this and say, oh, look, BFR is not that great. The review shows us that. So,
I'm just thinking that Tina Grape, the Zargi paper, they didn't do imaging. That's the 5 days they measured endurance and microvascularity. Like they didn't.
Well, that's what we focused on. Did they do imaging? I don't know.
Because
did they use ultrasound to look at the blood flow side of things?
Maybe that's what they did.
No, they use NIRS.
NIRS is what I thought.
Yeah, because like that was the whole thing with that paper for me, because they were trying to show if they could preserve muscle mass, but they didn't actually measure muscle mass.
It's true.
They
didn't report it.
They had previously shown that it mattered, like endurance mattered, and then they had this hypothesis as to why, which I thought was great, but then they just didn't go that extra step and measure muscle mass.
Well, I know their other study did because they reported the change in cross-sectional area.
Right, they had to.
Yeah.
They had to.
They didn't do any imaging.
So
I don't understand why that paper got included.
So like Lambert got dropped and Connecticut Children's got dropped.
I think Connecticut also got dropped because they had peds in there. And that was part of that. This systematic review specifically, I believe, part of the inclusion criteria, there was an age.
And I think they said one of the things that needs to be looked at is studies with people under 18. Yeah. They couldn't find any.
18 to 65 was the age
18 to 65 was their deal, and Connecticut Children's had kids under 18.
Let's just hope that they submitted this before that study was published.
Yeah,
it's possible.
We do know how long it takes these things to get through review sometimes, so it's possible. But
yeah. Well, the Zargi not having imaging, if that's true, that's a major
I just pulled
and they
it up
chose the 5-session prehab one to include.
confirm. And when you do a search for imaging, there's only one thing that pops up, and it's in the references.
Well,
Yeah.
and the other thing is they're
And
looking
there's nothing for ultrasound. Like if you do a control find or control F, whatever, the ultrasound, nothing comes up.
well, it also
Maybe
states
they
that
did a
they were looking
Springbok.
at, they're looking at the effectiveness of BFR versus similar in patients undergoing ACL reconstruction. And that other prehab study, the 3 times a week for 3 weeks, didn't look at anything after the reconstruction.
No,
it was
right,
only
I know.
prehab, and it was only the time point before
Right.
surgery. So the fact that that is included in what they're looking at here does not exactly match either.
It's all over the place.
So
Goodness.
Well, you
so
see
they
why
could
you
have
couldn't
just
get a
done a review
meta-analysis.
on Luke's study and said, here's our review on BFR post ACLR. So
Well, good stuff. I hope that gives people a little bit of ammunition if someone comes at them with these papers and says, why should I do BFR because of this or that? At least you have a deeper breakdown and kind of our thoughts of why I would go with the totality of the literature and not a single paper or a systematic review.
Yeah.
Yeah, I mean, seems to be good enough for Frank Noyes to change his practice in Cincinnati. So
Curlin Joe to only send patients out for BFR post surgery. Better be doing BFR.
Yeah.
All right.
Gotta be doing
anything
it.
else, fellas?
Not on this, but hey, we should kind of tease a little bit. So we are now offering ultrasound, introduction to ultrasound courses.
Speaking of imaging.
Yeah, speaking of imaging. So if you want to just learn how to do this and then do a study and get appropriately included into this review the next time they do it, we can help you get there. You check the website to find out where those are going to be. We're also actively coordinating sites. So if you want to host, send Ben Weatherford an email at ben@owensrecoveryscience.com.
I would complain, Kyle, but basically all roads lead to my email.
Info goes there, big goes just send them
the
to
website
Ben.
goes there. It's all going to me.
He gets the majority of
No,
those
dude,
emails.
you can send it to my email. It's ben@ors.io.
Yeah, I've got your local rep. His phone number is
No, but we're excited about it. We have Stephen Ramsey, who's a stud in the ultrasound world. And not only is it to understand how to measure changes in muscle and look at muscle architecture, so you can show objectively did they make positive changes or going south. Also looking at tendon, looking at bone, and maybe even more importantly, a lot of safety measures like how to rule out for DVTs and other more kind of bigger scary things that you might see in the hospital setting as well. So it's going to be badass.
Yeah, it's a pretty good course, and it's pretty easy to do. Once you kind of figure things out, what you're looking at and whatnot. Obviously the heart and things like that take a lot more time, but on the muscle side of things, it's pretty easy. You get an ultrasound, literally just you put it on the quad or what have you, and it's right there. And then the other thing of it is there's so many different devices out there on the market now that make it a lot more clinic friendly, where you don't have to wheel this big cart around and whatnot. Literally you have these little devices with an ultrasound probe and an iPad, and you're good to go. The technology is just continuing to kind of advance too with AI. I mean, some of the programs and what they're coming up with is literally it'll tell you, like you put in like what you want to image, and it basically directs you how to actually do that. And then all your measurements are done through the system. You know, you just draw a line for your thickness, for pennation angle. You put the lines there. It'll give you an angle. So it's pretty good, man. It's a pretty good course.
Yeah. The price point, you don't need that 40,000 for the big GE anymore. It's just a couple $1,000 and you can do this on your iPad, which is crazy. It's awesome.
Yeah.
And we're even in discussions with one of the companies of getting a more rehab MSK AI driven for the rehab side type of device, where it even will potentially like be telling you what anatomy you're looking at when you put it on there. So you don't even have time, maybe even have to know what it is. So it's going to be badass.
This is definitely a direction that the physical therapy world is going to. I mean, in California, they're starting to look at Practice Act stuff. The ultrasound is kind of on the list of things to do. The APTA has really kind of done a good job in terms of sort of coordinating with the physicians groups, so that essentially as a physical therapist, you can hold the exact same certifications as a physician. You just have to kind of go through and do all the testing and everything. And so that's obviously the goal of these classes that we'll be offering, is to at least get you started on that road. There's much longer road to kind of get there, but we kind of get you started on that, and then obviously more to come in the future, for sure, on that front.
Speaking of ABTA too, they put our podcast up with the going over the VTE clinical practice guidelines on their website now.
Yeah,
so
that's cool.
Lots of good information. If people haven't listened to that, I think it's worth listening to, because the guidelines are very robust and have changed.
Yeah.
All right.
And those guidelines are in the show notes if you want to download it. Also want to mention, we are sponsoring next weekend the OSU Lower Limb Symposium. It's being run by Matt Bobman's crew, formerly ACL Study Day, now Evidence in Practice. That's a really comprehensive conference just on lower limb stuff. Some big name heavy hitters. Mark Paterno is going to be there. Laura Schmidt, Matt Itherburn, Dustin Grooms, Sue Sigward, and some other big names that I don't know. So it's really well put together thing. We're supporting that. We're also supporting Elite Hockey Rehab Conference in Colorado Springs in June, and Elite Basketball Rehab Conference in Vegas in July. And then of course Ben and I will be at NATA. Zach, you coming to NATA or no?
I have not been there yet.
Oh, you haven't been to NATA? Anyway.
It's in New Orleans this year, man.
New Orleans.
I mean,
hot and humid, baby.
And I guess speaking of ACL, last thing, we keep plugging stuff, but there's so much we've done. I forgot about it. MedBridge did the ACL symposium at the end of last year that Dustin kind of helped run, Dustin Grooms. And all of our talks are on the MedBridge platform now. If you want to go on, if you use MedBridge, you can go on there and get them, I think, for a limited amount of time. But lots of good ACL information out there. Phil Plisky and Dustin were two of the folks that helped run that thing. All right, man, I got to go to a cheer banquet.
Oh boy.
Yeehaw.
You got to get all dusted up.
I didn't realize I would be a sexy cheer dad, but here I am. So
somebody's got to bear that burden.
Wish me luck. Hopefully there's not a bunch of fights between the high school. It's really the moms I'm worried about tonight. So Mexican food, beer, and angry moms.
All
right, you guys. That's what I'm doing right now. Great talking to y'all.
All right.
Talk soon. All right.
Later.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.
One last thing before we get out of here. First, want to say a sincere thank you for listening all the way through, but also wanted to remind you that this podcast should not be considered medical advice. It is strictly entertainment. It's a way for us to try to keep up with what is ongoing within the BFR world. If you require some sort of medical attention, medical advice, please seek that from a licensed individual within your state. Thanks, and we'll talk to you soon.